All right, let's get started. This is Steve Beck, and welcome everyone to our webinar for January. We're calling it Managing Your Participation in Medicare and Medicaid, and we'll touch on those subjects and some related topics. I want to say one housekeeping thing, which we will typically say, and that is our next webinar is, I hope I have the date right, February 8th. And on February 8th, Bob Klopinski will be talking about a new FDA rule. It's a Medicare device rule, and the rule is now being applied to hospitals, clinics, and other providers. In effect, if you are putting together custom software to operate even an electronic health record system, FDA considers that a medical device. You're a manufacturer, and you may have to register with the FDA and then comply with some FDA rules about how you are, quote, manufacturing your device. So Bob has pointed out to us that some of the requirements of this rule will be coming online in April. And so I think it's a timely topic. I think Bob will give us a sense of what will happen with enforcement and whether enforcement is going to unfold in a way that is dangerous for everybody, or whether this is going to be a smaller, more gradual process. But it seems like this is something that people may not have heard of before and will need to hear. So that's February 8th. We hope you can join us, and you should be getting some emails on that topic for between now and then. So I want to set up what we're going to be talking about a little bit today. Everyone has been kind of anticipating fee pressure on physicians, really physicians and everybody else, but we're really expecting fee pressure on physicians. I think everybody knows that the reprieve that was provided by the federal legislature to the physician payment formulas programmed reduction of physician fee schedule under Medicare by 27.4% is only a 2-month reprieve while the government tries to get its act together and do something to deal with the budget and with the Medicare budget. So again, we are scheduled for this cut to happen beginning at the end of February, beginning in March, if the government doesn't act in a more permanent way. I think it's pretty clear that at some point we're going to face some counter pressure that may result in some compromise or some replacement of the physician payment formula, which has been in existence for the last almost decade, and each year the feds in effect repeal for the year and push back. And of course, that's only one of the things that's causing concern about physician fees. State budgets are underwater, so to the extent that the states are funding Medicaid programs, the states have an incentive to try to create a new world with regard to fees as well. And we have this sort of specter of healthcare reform that's out there. And healthcare reformers, I don't think really know what they're doing, but many of them say what we need to do is to change the delivery system. I think they don't know what they mean when they say that, but I can imagine a couple of different ways to change the delivery system. One of them is to turn primary care into something like fast food, to have it delivered by some less qualified person than a physician who's being directed by a computer system or a formula, and to have that system basically deliver drugs and be the delivery system for medications. The other part of that change to the delivery system may be the development of a big box type model. And we can see the market reacting in a way that creates both of those approaches to a new delivery system. There's a backlash. People who are currently operating not as a fast food place, not like the McDonald's of healthcare, but are a restaurant. Some of them say, well, maybe what I want to be is a gourmet restaurant. I'm not really wanting to compete with McDonald's. I want to reform my part of the delivery system by changing in another direction. I want to be a counselor, not a person who is directed by a computer system as to what to do. The other thing that happens in the minds of the healthcare reformers is to change the payment system. And we certainly have heard lots of discussion in recent days about changing the payment system, both so that we can create some outcome-driven payments, and so that we can create incentives that will deal with specific patient populations, specific payers, all of those things. So when we listen to what is happening with our clients, and we're talking about primarily, in this case, physician groups who are facing this, but it may be physician groups who are owned by hospital systems or other healthcare systems, and it may be tiny little 1 or 2 person doctor groups. What we hear them doing is wondering how they can participate in the next round of change in an effective way and in a way that doesn't destroy their revenue streams. And many of them think about a number of different strategies. Many of them say to themselves, well, we need to try to improve our case mix. We need to try to make it so that we have a better population of patients. That might be moving the clinic. That might be changing the way, the kinds of services that we provide to create a better case mix. Or it may involve trying to adjust or manage a schedule so that we encourage good paying work and increase the quantity of good paying work. And a lot of people ask the question, which strategies are okay, which strategies are fraught with legal problems? Can we do the things that we're planning to do and what we've heard our competitors are doing to try to improve the outcome? I'll give you one more little piece of this puzzle to set the stage. That is a statistic, a random statistic, I guess, that I got from the American Medical News. They said somebody did a study and determined that physician acceptance of new Medicare patients had decreased to 92.9% in 2008 from 95.5% in 2005. They said 3% of members have opted out of the program, and 61% of the surveyed people said that they would consider leaving Medicare if the payments were significantly reduced from current levels. That means 2 things. Number one, a lot of people are out there wondering whether they should continue to participate in the same way, or is there a way that they could change the way they participate in public payment programs and in other payment systems. And it also probably means that the government, which thus far has been relatively okay with the opting out program, concierge care, and some of the other mechanisms that people use to manage their participation, may not be as sanguine about it sometime in the future. And they will undoubtedly sort of participate in this process of change interactively. And if a lot of people do things that they don't like and that reduces the access for their beneficiaries to health care, they'll probably find ways to prevent that. So that's set up. Katie Douglas is going to sit down at the microphone next and give you some thoughts about pricing differentials. That's one of the strategies that people use. Katie Burkhardt is going to follow up then with some discussion of interest systems, charity care, the idea of limiting Medicare and Medicaid, the idea of opting out, and then I'm going to come back at the end and give you a little bit of a refresher on concierge care. That's all from me.
Thanks, Steve. So as Steve mentioned, I'm going to focus a lot on pricing patterns that that providers can engage in, as well as kind of other activity that affects how services are provided to Medicare as well as Medicaid and even private pay patients, and how those services are paid for. So the question that we often get is whether you can have different prices for different patients. The short answer here is yes, but you should proceed with caution. Of course, everyone on this call has payer contracts, which may provide for different reimbursement rates from different payers for the same service. It's all a matter of negotiation. However, having those different prices could result in some interesting consequences. One of the biggest consequences is what it could do to your usual and customary fee, which may affect your payment from other payers. Many payers, including Medicare and Medicaid, base payment, at least in some way, on the provider's usual and customary price for the service. And payers vary on how they define usual and customary, which I'll get into a little bit later. But if you have radically different prices for services and you've reported a certain usual and customary fee to a payer, the payer could argue that you've misstated your usual and customary rate and try to pay you a different rate than what you think that you are entitled to. So if a third-party payer is not involved, or if you don't have a contract with a third-party payer, then the notions of implied contract come into play. If you don't have an agreement with the patient or the payer for payment ahead of time, then your receipt of payment for your service is based on an implied contract with the patient. You've provided a service, and now the patient has to pay for that service. A similar situation is, if you pull up to a gas station and you pump the gas, it's implied that you are going to then pay for that gas. The same is true for healthcare services. However, if you have a situation where you're charging one patient a much higher rate than what you charge the next patient, then that first patient that first patient gets wind of this lower price, that patient could challenge your price as unreasonable and refuse to pay it. And so if the patient challenges you in court, the court is likely to impose some sort of reasonableness standard, and so it could result in you not getting paid the rate that you had charged. So because of this, it is important to have some sort of rhyme or reason to your pricing mechanisms. So a variation of the previous question is, can different physicians in the same group have different prices for the same service? An example of this would be, let's say you have a large group with several locations, and one of your physicians in the location wants to charge $50 for an eye exam, and another physician in a different location wants to charge $25 for that same exam. There's nothing prohibiting this, but again, it can mess with your usual and customary charge. So we've seen situations where, a payer is going to, well, first of all, the contracts are often unclear as to exactly whether the usual and customary rate is the rate by code for the service or by the practitioner. So if you bill out as a group rather than, each individual physician billing out separately, then you should probably assume it's by code. And so because of that, you can charge different rates, but it will affect your usual and customary. Okay, so speaking of different prices, one question we get a lot is whether you have to give Medicare your lowest price. Surprisingly, most people think that you do have to give Medicare your lowest price, when in reality, Medicare pays the lowest of three different amounts. One, the provider's actual charge. The second is the Medicare fee schedule amount, or the provider's usual and customary charge. And Medicare has a definition for usual and customary. It's your median charge, or the charge that falls in the 50th percentile of all your charges. So bottom line is that Medicare does not necessarily get your lowest price. Moving on from Medicare, it's also commonly thought that Medicaid needs to be billed your lowest price. Since Medicaid is administered by the states, the answer to this question will vary depending on what state you're talking about. We obviously don't have time to delve into the Medicaid requirements for all states, and I know people are dialing in from different states today, but just for purposes of example, we'll look at Minnesota and Iowa. So Minnesota Medicaid requires you to bill Medicaid your usual and customary charge. However, usual and customary is defined differently than how Medicare defines it. Under Minnesota Medicaid, the usual and customary is the amount that you charge to those patients that constitute the largest percentage of your business. So instead of using the median, which is what Medicare does, Minnesota uses the mode charge. And then Iowa, on the other hand, follows the Medicare. So bottom line is that you need to see what state Medicaid rules say, and it's most important to just keep in mind that states will vary on this. So next is whether you can require patients to pay more than their insurer reimburses. Again, this will vary depending on whether Medicare, Medicaid, or a private payer is paying. So an example here would be if a patient comes into your office and says, his payer is Blue Cross. However, you know that Blue Cross's reimbursement for that particular service is low. So the question is whether you can tell the patient that you're not going to accept Blue Cross and instead require the patient to pay out of pocket for those services. And that way, you can charge more than what you know you would otherwise get reimbursed by Blue Cross. So the first question you have to ask is whether you have a contract with Blue Cross. And if you do, you'll need to see what the agreement says. Most payer contracts have hold harmless provisions and payment in full provisions that basically say that you must charge the insurer for covered services and you cannot charge the patient for any extra amounts other than co-pays and co-insurance. So if you have a contract that says that, then you would not be able to charge the patient more than what you'd otherwise get reimbursed from Blue Cross. And if you don't have a contract with the payer, then you're free to charge the patient more than what you know you would get reimbursed from the payer. However, you want to keep in mind the issues I spoke about earlier regarding the enforceability of implied contracts, and it's possible that your price could be held to some sort of reasonableness standard. The answer is pretty similar with respect to Medicare and Medicaid. If you're participating in Medicare, you're required to bill and accept payment from Medicare for covered services. And Steve will talk about this a little bit later as well, but if it's a non-covered service and you're going to want to make sure that you give the patient an advance beneficiary notice or an ABN, making the patient aware of his responsibility to pay if Medicare denies the payment. And if you're non-participating but you haven't officially opted out of Medicare, then the Medicare limiting charge comes into play. And in this case, the most you'll be able to charge the beneficiary will be 15% over Medicare's approved amount for the service. And Katie will talk more about opting out and non-participating and the differences between the two. If you have opted out of Medicare, then you can pretty much do what you want. Again, keeping in mind the concepts of implied contracts. Medicaid, again, is a state-by-state issue. Many states do limit or prohibit balance billing patients, so you want to make sure that you check the state-specific laws and regulations on this. Okay, what if you want to charge a patient for extras like phone calls? Each payer has different rules about what you can charge. And we'll talk about this more when we talk about concierge care, but under Medicare, you can't charge a beneficiary for covered services. And if Medicare pays for it, then you can't also charge the beneficiary for it. And whether it's paid for, whether it's considered a covered service, will depend on the circumstances and what exactly is being provided. For private payers, again, you should check your contract. Almost all contracts will say that you can't charge members for covered services. The question is how the payer defines covered service and whether the payer would consider a follow-up phone call from a physician in connection with a covered service that had been provided earlier, whether that phone call would also be considered a covered service. If you don't have a contract with the payer, then once again, you can pretty much charge for whatever, again, keeping in mind the concepts of implied contracts. Okay, so what about patients who are no-shows? Can you bill the patient if the patient doesn't show up for an appointment. As the theme with all of these questions, it depends on who would have paid for the service had the patient kept the appointment. For private payers, check your agreement. You're going to want to see whether there's anything specific to missed appointments, which is not unusual. Sometimes contracts specifically do call out missed appointment charges. But you also might want to see whether the hold harmless language in the agreement applies only to covered services and how covered services are defined. There's a question of whether billing someone for a missed appointment is a way of billing for a covered service that was never provided. The counter argument to that is that, the missed appointment fee is not for the actual covered service, but it's for the inconvenience imposed on the provider and the lost business opportunity that the provider experiences by having, a now empty appointment time. Until a few years ago, Medicare's position on missed appointments was a bit unclear. Again, this is because Medicare prohibits a provider from billing a Medicare beneficiary for a covered service. There was the question of whether Medicare or whether CMS might, take the position that charging for a missed appointment was charging for the covered service itself. Well, CMS since, clarified its position on that and has issued specific guidance saying that physicians, clinics, and hospital outpatient departments may charge beneficiaries for missed appointments. And the reasoning behind this, as I mentioned earlier, is that no-show fees are not a form of billing patients for the covered service, but instead it's the charge for the lost business opportunity. However, if you are going to charge a Medicare beneficiary for a missed appointment, you do need to make sure that policy applies to all patients regardless of payer source, and that all patients pay the same missed appointment fee. Medicaid's a different story. Again, depends on the state. But, in Minnesota, for example, there's a specific prohibition against charging Medicaid patients for missed appointments. So it'll depend on what Medicaid program you're dealing with and what those specific regulations say about whether or not you can charge for missed appointments. And regardless of who the payer is, if you do have a no-show policy, it's very important to make that no-show policy known to the patient up front, just to avoid any sort of surprises on the patient end, because if the patient didn't know about it, it might be more difficult to collect from the patient. Okay, what about co-payment waivers? We get these questions a lot, and the answer depends on several different laws. If you're dealing with Medicare or Medicaid patients, you need to consider the federal anti-kickback statute, the civil monetary penalties provision, and regardless of whether you're dealing with Medicare or Medicaid patients, you're going to want to check state law because state laws will also often have kind of mini anti-kickback statutes that extend the provisions of the federal statute to patients regardless of payer source. Okay, so first the anti-kickback statute. This statute makes it illegal to offer, give, solicit, or receive any remuneration if the purpose is to induce or reward referrals for Medicare or Medicaid covered services. This is purely an intent-based statute that looks to the purpose behind the payment or remuneration. In an anti-kickback analysis, courts apply what is known as a one-purpose test, which basically means that an arrangement can have several legitimate purposes, but if even one of those reasons is to induce or reward referrals, then the whole arrangement is tainted and will violate the anti-kickback statute. So the reason this statute applies to the waiver of co-payments is that because when a provider waives a co-payment, the provider is giving something of value, the value of not having to pay a copay, to the patient. So realistically, there are probably only three situations where a provider is going to want to waive a copay. First is if the patient is in financial need. The second situation might be if the patient's a friend. And then the third situation is if the patient is a fellow provider. The reasoning behind the waiver for these different types of patients will probably differ. a waiver for our financially needy patients, likely because you don't want cost to be a barrier to the patient receiving care. But if the patient's a fellow provider, it may still be completely legitimate to waive the copayment, but you want to make sure that the purpose of that copay or of the waiver isn't because the provider's a good referral source and you want to keep the provider happy. The next federal law to consider is the civil monetary penalties provision. This law makes it illegal to provide anything of value that the provider knows or should know is likely to influence the beneficiary's selection of a particular provider. This is very similar to the anti-kickback statute, but that extra knows or should know language is what eliminates the pure intent-based focus that exists under the anti-kickback statute. So the CMP could become a problem even if you don't specifically intend to reward or induce referrals. The question is whether you as a provider know or should know that this copay waiver will make the patient want to select you as his or her provider. There is one specific exception to waiver of copayments under the civil monetary penalties provision, and it's for waiver of copayments for the financially needy. You have to meet the following 3 requirements if you want to satisfy this exception. The provider can't advertise the waiver. You can't routinely waive copays and deductibles for Medicare beneficiaries, and you must determine in good faith that the patient is in financial need or that reasonable collection efforts have failed. So if you meet these 3 exceptions or these 3 requirements of the exception, then the waiver won't be a problem under the CMP. But for other waivers, I think the first 2 elements are probably good rules of thumb when deciding to waive copays. You should never advertise it, and you shouldn't make it something that you do for every patient or for the same patient on a routine basis. You also have to consider state anti-kickback statutes, which extend the federal law to private payers or sometimes even self-pay patients. While these states usually are some form of the federal version, they aren't necessarily mirror images of their federal counterpart. So it's important to review the state version carefully to make sure that the practices are covered. Sometimes there may be specific exceptions, or the state version might have more strict prohibitions. In general, though, the state versions do look to the intent of the provider in waiving the copay. So, if you're usually these waivers of copayments come from good reasons, so it probably won't be a problem. So if you're pure of heart, it's probably going to be okay. And for private payers, it's always important to check your contract to make sure that there's nothing that specifically discusses copay waivers, because we've seen that before. So with that, I will turn it over to Katie, and she will talk about putting a patient into collections. Okay, never mind. I guess I will talk about putting a patient into collections. Little miscommunication there. Okay, so this, whether or not you can put a patient into collections does vary depending on whether you're a clinic or a hospital. Hospitals are concerned about whether they can claim bad debt on their cost report. And there are requirements that a hospital does have to make certain reasonable collection efforts to show that it truly is bad debt and that there was actually efforts made in collecting that. It's not the same for clinics. Really, it's just whether or not there was the actual charge and whether there was actual fee that you have been unable to collect. But generally, like, actual collection efforts are not a factor in that analysis. So when can you claim bad debt? The debt has to be related to covered services and derived from the deductible or co-insurance amounts. You do have to establish, again, this is with respect to hospitals. You have to establish that reasonable collection efforts were made and that it was actually uncollectible and when you claimed it as worthless. And these requirements are all spelled out in a specific regulation that is cited at the bottom. Okay, charging interest on debts. This is a little bit similar to the collection efforts. There are specific requirements on in both federal and state laws regarding whether or not you can charge interest on debts. At the federal level, it applies to anybody who extends credit. The Federal Truth in Lending Act applies to anybody that you extend credit to. And if you fall under this, you have to make periodic disclosures that are required under the Act. There are also state usury laws, and you need to consider both Medicare and Medicaid policies. So Katie will get a little bit into that.
So when you're talking about the state laws, they're obviously all going to be different. In Minnesota, it will, and in Georgia, for example, they'll depend on whether there's a written agreement, and there are going to be certain percentage thresholds that are going to kick in. So interest is kind of tricky, and you'd need to have your state law expert be involved in that decision. Another related question that we get is whether you can charge interest on balances that Medicare patients or Medicaid patients have. So talking specifically about Medicare, it's interesting, WPS, which is the carrier for our region, and a couple other carriers, and now CMS, we've heard from them directly, say, either in written guidance or in conversations with them, say that a supplier cannot charge interest on patient balances. And they cite to this regulation, which basically says that the supplier can only collect certain payment, which would be either the difference between the Medicare approved amount and the Medicare Part B payment, any deductible, and any co-insurance for the services. So those are the only payments you can collect for the services. Now, obviously, the counter argument for charging interest on the balances is going to be that the interest charge is not a charge for the service. Rather, it's a charge to cover the missed investment or business opportunity when you don't have the money that you're supposed to have, basically making the supplier whole. So that seems like a really logical, sound argument. And in fact, Medicare and carriers do actually apply this reasoning in the context of a missed appointment. And somebody actually sent in a question asking for the cite to the missed appointment, and it's in a guidance or Medicare Learning Network manual provision. But basically here they're saying that a provider or a supplier can charge for missed appointments because that charge isn't for a service, but rather it's a charge for a missed business opportunity. Seems like this same logic should apply in the context of charging for interest on self-pay portions. But we're seeing that the carriers and CMS are not taking this position. So be aware that we think there's a good argument that based on their missed appointment rationale that you can charge interest, but it can be risky because this isn't what Medicare is. They're not agreeing with us on that point. I'm going to talk briefly about charity care because that's not totally related or not exactly about Medicare, Medicaid, but it is a pricing question we get kind of in the context of all of these others. Basically, it's when do you have to provide charity care? And so first you need to make the distinction between the may and the must. You clearly are permitted to provide charity care so long as the purpose is charity and not to get somebody to come back for services that they're actually going to pay for or somebody's going to pay for. And the question is whether you have to, and this is really going to come up for hospitals. Usually when you hear about charity care, you read about all the stories about how healthcare providers aren't providing enough charity care, All the providers are really lumped into one category, but we're really talking about, this is really a big issue just for tax-exempt nonprofit entities like hospitals. And that's because an entity that's exempt from federal taxation has to be organized for one of several permissible purposes, such as charitable purposes. Now, a lot of people think that the only way to get to fulfill your charitable purpose is to provide charity care, free services. But there are a couple other ways to do this, and you could be providing services or doing activities that advance education and science and those sorts of things. So providing charity care isn't necessarily the only way to be charitable. But that being said, there's been a lot of focus on this lately, particularly because the 990 now asks hospitals to describe their charity care policies in detail, assuming that they are doing some sort of charity care. And there's often a question of what percentage you'd have to provide. And there's not a specific percentage from the IRS now. Some people say you have to provide 5% of your revenue in charity care, but they actually haven't come out with an official charity care minimum. So we've been talking about federal tax exemption, but states also have their own tax exemption rules that may require charitable activities from providers. For example, I think the state of Illinois has proposed the concept of having a minimum amount of charity care for state tax-exempt hospital. So as you can see, the theme throughout this is there's the federal law, and then you always have to check your state law. Medicare does provide some guidance on how a provider can make a determination as to whether a patient is indigent or unable to pay for services. And there's some manual provisions. Basically, you can deem a patient who's eligible for both Medicare and Medicaid as indigent, but if you don't have a dual eligibility situation, then you would need to follow kind of the factors in the manual. What's key here is that the provider and not the patient has to be deciding who's unable to pay and whether charity care is necessary, and so you can't just base your determination on what the patient is telling you. You have to look at a number of factors. And then there also has to be no other source of payment that would be covering the services. So takeaway here is that if you are making these determinations, it's important to retain documentation showing what you've decided and how you got there in case somebody comes asking later. Okay, so you've learned about some of these pricing issues, and now you're sort of tired of dealing with them. So you're still enrolled in Medicare and Medicaid, and you want to know if you can just stop seeing patients. And so let's start with Medicare, and there are a few variations on this question. The first is whether you can stop seeing new Medicare patients, and then the second is whether you can just stop seeing all Medicare patients altogether. So we're talking on the supplier side, the non-hospital side right now. In both of those two scenarios I just posed, the suppliers are going to want to consider the Federal Age Discrimination Act. And the reason that we have to think about this is because an entity that receives federal funds is prohibited from discriminating based on age. However, there's an exception, or sort of a way out of this. You can take an action that might disproportionately affect an age group if that action is based on a factor other than age, so long as that factor that you've chosen has a direct and substantial relationship to your normal operations. So this is how it's going to play out. An enterprising regulator is going to look at your decision, clinic's decision to stop seeing Medicare patients. And they're going to say, well, you're discriminating. They don't like it, so they're going to find a way to say you're discriminating based on age. And your counter to that is going to be clearly that the purpose of cutting off Medicare patients isn't about their age, but rather it's to avoid the low reimbursement rates you're getting from Medicare, or maybe the hassle of dealing with Medicare and the costs associated. So, in other words, the low reimbursement rates are really the reason you are stopping your flow of Medicare patients. And the fact that it has a disproportionate effect on an age group is okay under the law because that low reimbursement rate reason is a factor that has a direct and substantial relationship to your normal business operation. So this is affecting your practice, and that's the reason you're doing this. So that's your counter back or your defense in this situation. I think it's a decent, sound argument. It's not a slam dunk, and there's no guarantee, but it's pretty obvious that the reason people are stopping accepting new Medicare patients is because of the reimbursement rates and not simply because of the patient's age. So the Federal Age Discrimination Act also applies to providers, but the reason I'm separating the providers here is because if you are a provider which is a hospital, home health agency, rural health clinic, or a rural health clinic, which would be any entity that has an agreement with CMS, then you could run the risk of CMS terminating your provider agreement if you stop seeing Medicare patients. They have that as grounds for termination if you were placing restrictions only on Medicare. So if you're shutting off your practice only to Medicare patients, and just seeing private patients in your provider, this could be a real issue. Also, I don't have a bullet point on this slide, but it's important to keep in mind that there are professional obligations under state licensing laws. For example, many physician licensing laws and case law prohibit patient abandonment and conduct that would put a patient's care in danger. So if you stop seeing Medicare patients that are already your patients, you have an issue with abandonment if that person is in the middle of treatment and if you're stopping care to them could place them at danger. So just be aware of state and accrediting body rules and laws that would have some effect on these decisions. On the Medicaid side, again, Medicaid rules will vary. As an example, in Minnesota, the restrictions that you place on patients have to apply to all patients if you're enrolled as a Medicaid healthcare provider in Minnesota. And you also have to report any restrictions to the Department of Human Services. So this is going to be on their radar if you make these decisions. Also, your participation in other Minnesota state programs like workers' comp, state healthcare worker insurance, that's tied to your participation in Medicaid. So you have to have at least 20% of your business as medical assistants in Minnesota in order to participate in these other programs. So be aware that each state might kind of make it harder for you to get out of Medicaid in various ways. Okay, so now we're at the point where you're just not going to deal with Medicare anymore based on all of sort of the analysis you had to go through to provide services, and that's just not going to be, you decided it's not going to be something you want to do anymore. So you're going to opt out. Now, Steve's going to talk a little bit more about the reasons for opt-out, and I think they're also out there and pretty apparent as to why people are doing it. But, what does opt-out mean? If a practitioner opts out of Medicare, then he or she is permitted to contract privately with Medicare patients to provide covered services to them. And in that case, then the Medicare patient agrees to pay fully out of pocket for Medicare covered services after signing a private contract between them and the provider. So, and in the same instance, the practitioner agrees not to submit a claim to Medicare for a 2-year period. So who can opt out? It can only be individuals listed on that bullet point. An entire clinic can't opt out. So if you want a clinic where nobody participates in Medicare, each practitioner must separately opt out. And likewise, the decision of one practitioner to opt out of Medicare doesn't affect the ability of the clinic or group practice to bill Medicare for the services of other practitioners who haven't opted out. So of course, on your way out of Medicare, they make it sort of tedious and difficult, like all other things, to get out. And so there are a number of steps that you have to follow, and they're really important in order to make it effective. So the first is you have to file an affidavit with Medicare. The individual does. It has to say who they are. It has to be signed by the practitioner, and you have to basically promise that you won't submit claims to Medicare for 2 years. So that's the affidavit. The timing is really key in opting out because you have to get it right, otherwise it doesn't take effect and you're stuck. you're stuck if you're already in. So for participating individuals, you can only opt out at certain times, and your opt-out has to be effective on the first date of one of the calendar year quarters. In order just to say you want to opt out on April 1st, then you need to get your affidavit filed with a contractor 30 days prior to April 1st. So it's really important to get that, because then if you don't get in by the right time, then you're pushed off to the next date. For individuals who aren't already participating in Medicare, they also have to opt out in order to charge beneficiaries for covered services. But the timing is a little looser. You have to sign your affidavit, and the opt-out period will begin on the effective date of the affidavit, so long as it's filed within 10 days after you sign your first private contract with a Medicare beneficiary. So honestly, I don't really know how that's going to be regulated, but that's the rule. It's a little looser and it's different, so be aware of that. Really key on the timing piece is to remember to refile or opt out or renew your opt-out every 2 years. And it has to be the timing has to be right. You have to mark in your calendar when you opted out and make sure you get in your affidavit by that time after 2 years. Otherwise, then you're back in Medicare. Your opt-out stops being effective and you're back in, and there's this bizarre process for trying to get back out, but it's a huge pain. So just remember to renew on time. So you want to notify your patients, and this is really the time, your opportunity to send them a copy of this private agreement that you have to have signed between you and them in order to provide covered services and not bill Medicare and be able to collect from the patient. So the contract is absolutely necessary for people who would otherwise be covered by Medicare, obviously not for non-Medicare patients, or for emergency or urgent care visits. There's a laundry list of requirements that have to be in the contract. Kind of the key provisions are that the patient basically accepts full responsibility for payment of the charges. They have to know that they can receive covered services from other practitioners who haven't opted out. You have to state the opt-out period, and you have to give them a copy and, of course, retain all of your documentation in case you're audited in the future. And then do not submit claims to Medicare during that period. So interesting questions that come up. What about Medicare Advantage? Opt-out applies to Medicare Advantage. So you can't provide covered services to Medicare Advantage patients without a private agreement where the patient has accepted full responsibility. Medigap policies will not pay for covered services of an opt-out physician, and other supplementary plans may also choose not to pay for those services. I also believe that Medicare secondary payer payments will not be made for items or services that are furnished by a physician who's opted out and is under a private contract. So there are some interesting non-traditional Medicare issues to deal with as well. And then I will make the point, a question we get often is, can the practitioner opt out for certain services or for certain locations? And the answer in both those cases is no. The practitioner if they opt out of Medicare, they've opted out for all of their covered items and services, and for all jurisdictions where they're providing services. So that I'm going to hand it over to Steve, who will talk about concierge care.
Thanks, Katie. All right, so the theme of all of this is that providers are increasingly adapting to their patient population in an attempt to improve the return that they're getting out of the case mix. They're doing it both by bending their fee schedule a little bit so that it may apply differentially to different populations. They're doing it by managing the population that comes in the door. They may say we have a certain number of slots of type A and a certain number of slots of type B in any given day. They've got to deal with that whole thicket of rules that Katie described. And some of them are going in another direction where they're saying, well, we're going to change the delivery system, but we're not going in the direction of being a fast food provider. We're going in the direction of being a gourmet restaurant. And that's the people who are doing concierge care. Concierge care has been around for a little while. You know, I think it has gotten noticed by the government for something like the last 10 years. There are a series of studies that the government has done trying to figure out what the penetration of this concierge market is in the marketplace. The GAO studied it back in 2003 to 2005. Most recently, there was a MedPAC study that came out in 2010. Interesting results of these studies. It's very hard to figure out who's doing concierge care because they don't necessarily identify themselves to any government. They don't have to necessarily opt out, although some people do opt out in order to do concierge care. But in 2005, the GAO found something like 146 concierge doctors. In the most recent study, the MedPAC folks found something like 756 concierge doctors, and they said that's undoubtedly the lower level, the lower limit of the actual number. So we're getting more and more people that are doing concierge care, and what they're trying to do, just so that we sort of set the stage, is to say, instead of putting together a daily schedule that has 40 or 50 appointments, primary care or visit appointments per day where they see people for a very short period of time, let's see if we can reduce the population that we serve, have a limited number of patients. Each of those patients pay some amount annually or on a subscription basis. The annual amount might be $1,000, might be more, might be less. And those folks would get a benefit. They would get to consider their doctor to be owned by them, employed by them in some fashion, and they would get a set of benefits. So the concierge model, as we say, is growing. Now, people looking at the concierge model have identified a number of legal risks. Medicare may have a big concern that you're charging a beneficiary for a covered service, and that's a no-no. State insurance laws, second, might say, well, you're actually acting as an insurance provider because you're guaranteeing somebody that you are going to provide all of their care for them, and that's what an insurance company does. And there are a variety of other sort of smaller issues that people look at when they're analyzing this from a legal point of view. Medicare has thought about this issue for a long time, and each time they've looked at it, they've come to the conclusion that as long as what you're providing in your concierge model is non-covered services, and you're getting paid something extra for non-covered services, that's okay. That really goes back to this congressional letter to DHS in 2002. Conclusion was, we have a prohibition on private contracts for covered services that go beyond the normal payment mechanisms that we've set forth. But if somebody wants to deliver non-covered services to patients, that's okay. Didn't go very much further than that. In 2004, they developed this idea a little bit further, again said, okay for a concierge practice to provide non-covered services, but they pointed out that among the things that they considered to be covered are care coordination, a comprehensive assessment and plan, that I think in a way means doing a good job, and extra time. They thought time isn't an element. You're supposed to be doing whatever amount of time is required to provide the service that's the code applies to. And doctors putting together concierge care have said, well, we are going to provide non-covered services for our subscription price, and in order to deal with Medicare's requirement that it be non-covered services, we're going to make certain that it's non-covered because it's primarily a physical, an annual physical, and perhaps some other kind of specific call coverage, accessibility services, that kind of thing, that is explicitly outside or could be argued to be outside of the what you're supposed to have provided. That generally works from a Medicare perspective. You provide, set out in a contract that you're going to provide non-covered services, detail exactly what the non-covered services are, be clear that they don't include stretchy concepts that might seem like they fit into care coordination generally, in which the government will say is part of your normal service, and as an alternative, you can opt out of Medicare. Now, there's one gotcha here, and that is that Medicare keeps moving the bars to what they cover. So among the things that they have recently done is to add a welcome physical. They now welcome Part B beneficiaries to Medicare by paying for a physical within the first 12 months. If you're going to provide concierge care contract and the subscription is based primarily on the value of an annual physical, you've got to coordinate so that you're not providing that annual physical during the welcome physical period, because if you do, all of a sudden you've got a covered service and you may be violating that Medicare problem. So the other big issue, sort of big global issue that people talk about in the context of concierge care is whether you're violating the state insurances laws somehow. And you know, this gets back in a way to the analysis that insurance commissioners, some of them, did in the early days of gatekeeper medicine, where gatekeepers were getting paid in part from a pool of money that depended on whether somebody's total package of services exceeded some amount. And the state insurance people said, well, insurance really means taking a risk for services beyond your normal schedule of services or beyond what you can yourself directly provide. And people thinking about concierge care have said, well, you can't enter into a contract with somebody that says, pay me $1,000 and I'll provide all the health care you need. Now, that's kind of obvious. If you're a primary care doctor, you're not going to be providing all the hospitalization somebody needs or probably all the brain surgery that somebody needs. You're going to be providing the services that you typically provide, and you're going to provide them in an amount that doesn't exceed the total amount of time you've got. It's sort of like you're a shared employee of a group of people who've hired a doctor to work. The doctor works as time permits. Bottom line is you need to have the contract say that you're not agreeing to provide all necessary medical services for a fixed fee. It's important to not let your advertising or your promotion of the concierge care idea get in the way of what your contract says, and it's important to have a real contract. Now, there are some other legal risks with concierge medicine. People are a little bit worried when you move from regular delivery system to concierge care that you're going to be abandoning patients. Every state has got a little bit different laws or standards regarding what it means to abandon. In general, if patients are going to be covered, even if they have an emergency during the transition period, you're probably not going to be in trouble for abandoning. So this isn't an issue that is all that difficult to manage. Probably means that you want to take care of it in the patient's contract for concierge care and in all the promotion that you do. Make clear how you sign up and what that you're not running away from a patient who's got some kind of emergency condition. Also, probably useful to note that private payer contracts can view this the same as Medicare. If you've got private payer contracts that say you're going to provide all covered services, you've got to provide all covered services to those patients, and if you're charging them for something else, that's okay, but you can't charge them for something that's covered services. So to the extent that you are trying to conform the concierge offering to the covered service rules of Medicare, you also have to conform them to the covered service rules of your private payers. And then the last thing, you got to always be worried about anti-kickback prohibitions. If you're in the Medicare system, you need to be worried about whether you're paying somebody, waiving a copay, doing something else that, under some of the rules that one of the Katies was citing earlier, doesn't really work anymore. Bottom line, it seems like we're going to see more concierge medicine. It seems like there is some number of practices that are going to be looking at this as an approach. It is an approach that can be that doesn't require you to opt out of Medicare, but you can do even though you continue to be a participant in Medicare and in other private pay systems. And it's likely something that a large system could put together as one offering out of many from among its physician service line. Fairly likely that people will if the market continues to be there and people want to continue to buy the service, we'll expand this offering even while they are developing what I'm derisively calling the McDonald's version of healthcare. That's interesting. It's okay, and probably will continue to adapt. And it's also probably true that Medicare and the payers will get a little bit more nervous about it over time. All right, so we have blown through our hour again. It seems to go awfully quickly. I don't know if we have any questions. If we do, we will get back to you in writing. Thanks a lot, everybody.